You're sitting in your car outside the clinic, keys still in your hand, rehearsing whether today is the day you finally schedule that screening. For many people, cervical cancer screening has not felt simple. It has meant undressing, stirrups, a speculum, and sometimes a memory they would rather not revisit. The shift happening now is not flashy. It is quieter, practical, and potentially big, testing for high-risk HPV from a sample a person collects themselves. In May 2024, the FDA expanded approvals for the BD Unclarity HPV and Roche-Cobas HPV tests to allow self-collected vaginal samples in healthcare settings. That means the sample can be collected privately at a clinic, pharmacy, style setting, or mobile health site, depending on what local systems actually are. This is not a home test for everyone yet, but it is a door opening, especially for people who have avoided screening for years. The National Cancer Institute reports that almost 30% of eligible people with a cervix in the United States are not screened at recommended intervals. That gap is not about laziness. It can be about trauma, disability, transportation, cost, rural distance, gender dysphoria, childcare, or simply fear. This content is for informational purposes only and is not a substitute for professional medical advice. Always consult your doctor or a qualified healthcare provider before making changes to your health routine. To understand why self-collection matters, we have to start with the target. Cervical cancer prevention has been moving toward HPV testing for a reason.
Infection with high-risk HPV types is the necessary driver behind nearly all cervical cancers, which is why detecting HPV can identify risk of growth.
A Pap test looks for abnormal cervical cells. An HPV test looks for the virus that can set that cell change process in motion. The 2025 Enduring Consensus Guidelines say self-collected vaginal specimens are acceptable for primary HPV screening in asymptomatic average-risk people who qualify for screening. Average risk usually means no current symptoms, no recent abnormal screening history needing special follow-up, and no high-risk immune condition changing the plan. If you have bleeding, pain, unusual discharge, or a past abnormal result, consider asking whether a clinician-collected exam is still the better first step. The UPSPST draft recommendation supports high-risk AP primary screening every 5 years for women ages 30 to 65, using clinician or patient-collected sample. That age range matters because HPV is common in younger adults, and most infections clear without causing lasting problems. Screening strategy changes with age. The UPSPST draft still separates younger adults, recommending cervical cytology every 3 years for women ages 21 to 29, rather than primary HPV. So the headline is not everyone should switch tomorrow. The more useful message is this: the menu of screening options is expanding. Imagine Maya, who skipped screening after a painful pelvic exam in her 20s. Every reminder postcard landed in a drawer with unopened bills. She was not refusing prevention. She was avoiding an experience her body remembered as threatening. That distinction matters when we talk about public health. NACE leaders described the 2024 FAA approvals as a first step toward broader future options, including collection outside traditional settings as evidence grows. For someone like Maya, privacy changes the emotional math. A swab collected behind a closed door may feel possible where an exam did not. If pelvic exams have been a barrier for you, one approach is to say that directly when scheduling. You do not have to over-explain. Try asking, does your office offer primary HPV testing? And is patient self-collection available in the healthcare setting for people who are due? That phrase, patient self-collection, is useful. It tells the clinic you are asking about a specific approved pathway, not a random mail order kit. The current FDA approvals are for self-collection in healthcare settings, not brought over the counter home collection for cervical screening in the United States. Home collection is moving closer, and other countries already use it. But United States regulators still want more evidence on real-world follow-up. NICE SHIP Trial Network launched in 2024 to study self-collection approaches and help build the evidence needed for wider screening options. A positive HPV result does not mean you have cancer. It means high-risk HPV was found, and your clinician may recommend the next check. If your result is positive, consider asking which HPV type was detected, what follow-up is recommended, and when that follow-up should happen. Some HPV types carry higher risk than others. That is why labs and clinicians may sort results into different follow-up pathways. The self-collection guidelines focus on primary HPV screening, meaning HPV testing is the main screening test rather than an add-on after some. That is a mental shift. We grew up hearing pap smear. Now the first question may increasingly be, what is my HPV status? The 2025 guidance says, self-collected samples are acceptable for asymptomatic average-risk individuals, but not every person with a cervix fits that category. If you have had cervical precancer, immune suppression, the goal is not to replace every pelvic exam. Pelvic exams can still matter for symptoms, pregnancy care, pain, infections, and other concerns. The goal is to remove an unnecessary barrier when the screening question is simply, is high-risk HPV present or not? When you call, consider asking whether the clinic uses an FDA-approved HPV test that supports patient-collected vaginal samples in their setting. You can also ask where the sample is collected, who gives instructions, how privacy is handled, and how results are delivered. If transportation is hard, ask about community health events or mobile screening programs. Availability varies, but the question may uncover options. NICE notes that self-collection could help reach people who are rarely screened, including those facing geographic, physical, cultural, or personal barriers. This is where access becomes biology. A test only prevents harm when people can actually complete it, understand it, and return for care. For years, the system quietly asked people to be comfortable with the exam. Self-collection asks whether the system can become more comfortable for people. That is a different kind of prevention. Less heroic, more practical. Meet people where they are, then make the next step clear. The NetCI article quotes Dr. Nicholas Wensenson saying, screening is only one piece of the full pathway to prevention. So if you hear HPV positive, try not to panic. Ask for the pathway. What happens next is the clinically important part. For some people, the next step may be repeat testing. For others, it may be a closer look at the cervix. If cost is a concern, consider asking the clinic, health department, or insurer whether HPV primary screening is covered and what follow-up costs could be. The awkward truth is that access does not end at the first swab. It includes reminders, transportation, insurance, language, and respectful communication. If a provider says self-collection is not right for you, ask why. A good answer should connect to your history, symptoms, or risk factors. And if the answer is simply, we do not offer it yet, that may be true. Implementation often trails approvals and guidelines. You can ask to be notified when self-collection becomes available or request the least invasive screening option currently appropriate for you. For listeners who are vaccinated against HPV, screening still matters. Vaccination lowers risk, but it does not remove every screening recommendation. A practical question is, given my age, vaccine history, and past results, what screening schedule makes sense for me? The illustration still frames cervical screening by age group and test type, rather than offering one universal plan for everyone. That can sound frustrating, but personalization is not a flaw. It is how screening avoids both missed disease and unnecessary procedures. Back to Ma'am.
The first time she heard self-collection was possible, she did not feel brave. She felt relieved.
That relief is not a side note. It may be the difference between a person staying outside the system and stepping back in. If you are due for screening, consider making a short list before you call: test type, self-collection, privacy, cost, and follow up.
If you avoided screening for a long time, you can say that too.
Clinicians hear this more often than you might think. Shame is not a screening strategy. Clear choices, respectful care, and follow-up plans are much better tools. NACY's 2024 coverage notes researchers are gathering more evidence, especially for future approvals that could expand where self-collection happens. If this episode helps you ask one better question at your next visit, like and subscribe so more evidence-based health stories find you. The big picture is simple. HPV testing is becoming central because it looks for the infection that drives risk before cell changes progress.
Self-collection matters because the best screening test is not only accurate, it is also one people can actually access.
If you are between 30 and 60, 5 and do, ask your clinic what HPV screening options they offer and whether self-collection fits your situation. If you are younger, older, symptomatic, pregnant, immunocompromised, or have past abnormal results, consider discussing the right pathway with your healthcare provider. Preventive care works best when it fits real lives. This screening shift may help more people step through the door at their own pace.